So even though it sounds like brain stimulation is on the cutting edge of medicine, it's been around a very, very long time. So in about 49 AD, there was a physician in ancient Rome by the name of Scribonius Largus. And Dr. Largus had a lot of patients with pain of the lower extremities due to neuropathic pain from gout. And it turns out that there wasn't a lot of good medications, and the medications that they had really couldn't treat it, so patients were really in pain. One of his patients one day was walking along the riverside and stepped on an electrical torpedo fish, got a huge electrical shock. But what was really interesting was that the patient was pain-free for days after the electrical shock. So he let Dr. Largus know what happened, and because there wasn't an FDA back in ancient Rome, Dr. Largus went to the riverside, picked up some electrical fish, and started shocking his patients, and actually started that. That's the actual very first in modern medical literature of using electricity to treat a neurological condition. DBS is FDA approved for all movement disorders, Parkinson's disease, tremor, and dystonias. It's covered by all insurance carriers, including Medicare. It's something to be important for everybody to understand. The technology in of itself has also gotten better over time. Some of the technological features that we now have at our fingertips to help you in the best way possible is a rechargeable device. We also have leads, DBS leads that go into the brain that allow the person programming much greater flexibility than we ever had before. So we can minimize side effects and maximize the efficacy. Plus, the patient-facing, the things that we give you to control your device is now a very familiar thing. It's like an iPod or an iPad. So the whole experience is really designed around making this a familiar thing for patients. Future, within probably the next couple of years, you'll be able to get programmed from the comfort of your own home. So, I think the very first question you have to ask yourself is, am I a candidate for this procedure? With regards to Parkinson's disease, just a show of hands, how many people are here for a loved one with Parkinson's or Parkinson's disease, just so I can sort of tailor this discussion? So, okay, and how many people are here for just tremor? Okay, and then how much for dystonia? Great, so it's almost even, that's great. So let me just start off with Parkinson's disease. If you have one of three different things right here, you are an excellent candidate for DBS. Let me explain them starting from the bottom. Medication-resistant tremor, that's an easy one to understand. If you have a tremor that has been incompletely addressed by your medication, you are a candidate for deep brain stimulation. The second is drug-induced dyskinesias. Many of you have seen Michael J. Fox on television, those sort of uncontrollable writhing motions. These are the result of medication. It's a side effect of the medication. It tremendously decreases the quality of life. This is an indication for deep brain stimulation. And the last one, the one on top, the reason why I put it on top is probably the most important reason, because it's probably the biggest impact to the quality of life for Parkinson's patients. It's called a motor fluctuation. What do I mean by that? Well, most Parkinson's patients, when they first start taking their medication, it's almost like they don't have Parkinson's. The medications work super well. They don't, and by the time that they're beginning to come off their dose, they're already taking another dose. So they live in this really nicely on-medicated state. As Parkinson's progresses, that nice on-medicated state gets shorter and shorter and shorter. And so you kind of begin to go through this horrible roller coaster of good medicated state, bad medicated state, good medicated state, bad medicated state. People begin to sort of organize their entire lives around their medication schedule because they don't want to shut off in the middle of the movie theater or at dinner or at a party. And so as a result, they begin to sort of shut themselves in because it's really, really scary. What deep brain stimulation does is it takes that up and down pattern and bring it back to the original pattern where you essentially are very well controlled longer throughout the day. With regards to tremor, it's a little bit more straightforward than Parkinson's disease. disease, essentially, when the tremor interferes with the quality of your life, eating, dressing, socializing, and essentially becomes intractable to one of two medications, either beta blockers or primidone or mycin, the same drug, you are a candidate for this surgery. The other drugs that are tried, Botox and other forms of the medication, quite frankly, are just very bad at controlling tremor. If you don't get a great response to either beta blockers or primidone or mycin, you are an absolute candidate for this surgery, and it can change the quality of your life. With regards to dystonia, now dystonia isn't a single disease, it's a constellation of symptoms as a result of different causes, but we treat them all the same way with Botox and anticholinergics and baclofen and benzodiazepines, but these are all really sort of indirectly affecting dystonia. There's no specific drug, anti-dystonic drug. We're sort of an indirect way treating them. And so if you are having significant symptoms despite these medications, you are a candidate for this surgery with dystonia. We also like to do genetic testing because there are different forms of genetic testing that essentially predispose you to an even better result with DBS, one of them being DYT1, but there are other genetic forms that are good. The workup towards surgery I always liken to launching the space shuttle. There's a lot of hoops that we put you through, but we do that all in the service of making sure that it's safe for you and actually gets the best results for you. So patients will have to undergo a certain degree of behavioral testing specific to their disease. For Parkinson's disease, it's called a capsid test. There are tremor and dystonia gradient scales, and we videotape it. Why do we do all that? Because we have a monthly conference where 14 or 15 movement disorder neurology minds get together and basically discuss your case and really come up with the best plan for you. So when you come to Sinai, you're not just getting one doctor, you're getting an entire team. You also undergo neuropsychological and psychiatric evaluation. Many of these movement disorders result in cognitive issues and psychiatric and mood issues, and if we don't address those as part and parcel of your treatment plan, you won't get the most benefit. So when you come to see us, we treat you like a whole person. It's not just placing an electrode and good luck to you. We treat you as an entire person. We try to get a great 360 view on what's going on, how you're functioning, and this is a part of the pre-surgical workup. And then finally, you undergo a specific brain mapping process to your brain so that we can place these electrodes in a patient-specific manner. So let's talk a little bit about the surgery itself, what it can and cannot do for you. With regards to Parkinson's disease, there are now results of many 5-plus-year studies. So as I said to you, DBS has been around now for close to 25 years. So it's no longer an investigational thing. And we know the long-term follow-up would be brain stimulation. And it significantly reduces all of what we call the cardinal symptoms of Parkinson's disease: rigidity, bradykinesia, and tremor, 70% reduction in dyskinesias. The average patient gets a 50% reduction in their medications. Most importantly, as I said to you before, is this improvement in best on time and reduction in worst off time. These two things result in the greatest quality of life. As all Parkinson's patients are a little bit different from one another, I'm going to show you another